Hello everyone, I am Mohammed Hamama, and this is your ASCP preparation camp. In this camp, we will go through each topic on the ASCP lecture list. In today's video, we'll delve into the exploration of essential thrombocythemia, another intriguing chapter within the realm of myeloproliferative neoplasms. Essential thrombocythemia, or ET, falls under the umbrella of clonal myeloproliferative neoplasms, an intricate landscape of cellular anomalies. This condition is characterized by an upswing in megakaryocyte, the process of megakaryocyte production, and a resultant surge in platelet count. Platelet counts often soar above the norm, crossing the threshold of 600 billion per liter and sometimes reaching even higher, 1 trillion per liter. Essential thrombocythemia's incidence remains elusive to pinpoint. Using the PVSG diagnostic system, the estimated occurrence hovers between 0.6 to 2.5 cases per 100,000 persons annually. This condition predominantly affects those aged 50 to 60 years, while a secondary peak emerges around 30 years in women. Peering into the pathogenic mechanism, we find mutations similar to PV, albeit at a lower frequency. The JAK2V617F mutation, for instance, surfaces in around 55% of ET patients, exerting its influence on the cellular landscape. Meanwhile, MPL exon 10 mutations, specifically MPL W515L/K, play a role in 3% of ET cases, adding another layer of complexity. Other players step onto the stage: TET2 mutations in 4.4 to 5%, ASXL1 mutations in 5.6%, LNK mutations in 3 to 6%, and IDH1/2 mutations in 0.8%. Clinical presentation often unfolds with over 50% of ET patients being diagnosed due to elevated platelet counts. Others seek medical attention because of vascular occlusion or bleeding, with microvascular thromboses wreaking havoc in digits and major arteries or veins. Bleeding, on the other hand, frequently originates from mucous membranes, particularly in the gastrointestinal and upper respiratory tracts. Around 50% of patients exhibit splenomegaly, a noteworthy factor that can distinguish between PVSG and WHO criteria. This distinction is a result of excluding ET diagnosis in patients meeting prefibrotic stage primary myelofibrosis criteria. Aspect of diagnosis. Distinguishing essential thrombocythemia from secondary or reactive thrombocytoses and other myeloproliferative neoplasms is of paramount importance. Thrombocytosis can emerge from various causes: chronic blood loss, anemia, inflammation, infection, or non-hematogenous neoplasia. The PVSG diagnostic criteria were devised to set essential thrombocythemia apart from other myeloproliferative neoplasms. Meanwhile, the World Health Organization introduced a set of criteria aimed at ensuring a more precise diagnosis. These criteria require the fulfillment of 4 major criteria, forming the foundation for the diagnosis. Notably, the platelet threshold has been adjusted to more than or equal to 450 billion per liter to encompass those with platelet counts between 450 to 600 billion per liter who might experience hemorrhage or thrombosis. All WHO criteria must be met to avoid false positive ET diagnoses. Significant megakaryocyte in bone marrow with no major changes. No criteria matching other MPNs, myelodysplasia, or myeloid neoplasms. Presence of JAK2V617F or other clonal mutation, or absence of reactive thrombocytosis. Bone marrow analysis distinguishes ET from MDS and PMF. JAK2V617F mutation identifies ET, excludes reactive thrombocytosis. The role of JAK2 and MPL mutations is pivotal. The JAK2V617F mutation is present in around 50 to 60% of ET patients, supporting accurate diagnosis. Beyond mutations, peripheral blood and bone marrow analysis provides valuable insights. Peripheral blood films exhibit the telltale signs of early-phase thrombocytosis, varied platelet size, shape, and clustering near the film's edge. While segmented neutrophils might increase, basophils typically remain unaffected. Erythrocytes tend to be normocytic and normochromic, unless iron deficiency from excessive bleeding is at play. Early-phase bone marrow tells its own story, marked megakaryocytic hypercellularity, clustered and enlarged megakaryocytes, and certain features that set the stage for further exploration. Major findings within the peripheral blood, bone marrow, and even extramedullary sites further contribute to the diagnostic puzzle. Bone marrow biopsies can be enlightening, but certain features raise questions, prompting deeper investigation for alternative diagnoses. For patients with platelet count greater than 450 billion per liter, certain bone marrow features raise doubts about ET diagnosis. Increased erythropoiesis or granulopoiesis suggests alternative diagnoses like PV or PMF, respectively. Bizarre/atypical megakaryocytes alongside these features are especially suggestive. Dyserythropoiesis or dysgranulopoiesis might point towards myelodysplastic disorders, steering us toward specific genetic aberrations. The process of diagnosing essential thrombocythemia, intricate as it is, illustrates the meticulous nature of medical inquiry. As we dive deeper into the realm of essential thrombocythemia, it's crucial to understand how treatment and prognosis intertwine to shape the journey for patients. The primary focus of treatment in essential thrombocythemia revolves around averting or promptly addressing complications linked to elevated platelet counts. To achieve this, the suppression of marrow megakaryocyte production takes center stage. One effective approach involves using an alkylating agent like hydroxyurea. Similar to polycythemia vera, patients treated with hydroxyurea for essential thrombocythemia face a less than 5% risk of malignant transformation to acute leukemia or myelofibrosis. For patients who might be intolerant or resistant to hydroxyurea, there are alternatives. Younger patients could consider interferon alpha, while busulfan is an option for the older population. Preventing thrombosis is another key aspect of treatment. Low-dose aspirin is often recommended to lower the risk. In cases where patients prove refractory or are at high risk, JAK2 inhibitors come into play. INCB 018424, for instance, demonstrated platelet count reduction and symptom improvement. The prognosis for essential thrombocythemia patients is generally positive, particularly if major thromboembolic or hemorrhagic complications are avoided. Vaso-occlusive events can lead to a range of symptoms, from erythromelalgia and transient ischemic attacks to seizures, cerebral or myocardial infarctions, headaches, dizziness, visual disturbances, and dysesthesias. On the other hand, hemorrhagic complications might manifest as mucous membrane or gastrointestinal bleeding, as well as ecchymosis. The median survival for essential thrombocythemia patients is around 20 years, a remarkable figure even for younger patients. However, the development of post-ET myelofibrosis could influence this, especially if chromosome abnormalities are present. As we venture further into the intricate world of myeloproliferative neoplasms, we now focus our attention on primary myelofibrosis, often referred to as PMF. PMF, previously known by various names such as chronic idiopathic myelofibrosis and myelofibrosis with myeloid metaplasia, stands as a clonal MPN marked by splenomegaly and ineffective hematopoiesis. In PMF, bone marrow features prominently. It becomes hypercellular, undergoes fibrosis, and showcases an abundance of megakaryocytes. These megakaryocytes, pivotal in PMF, exhibit distinct characteristics such as enlarged size, pleomorphic nuclei, coarse segmentation, and areas of hypochromia. Shifting our focus to peripheral blood, a glimpse at the blood film reveals the presence of immature granulocytes, normoblasts, teardrop-shaped RBCs known as dacryocytes, and abnormal RBC shapes. PMF's clonality becomes evident through cytogenetic abnormalities detected across various cell types. In female patients with heterozygous glucose 6-phosphate dehydrogenase isoenzymes, PMF cells have a single enzyme isotype, while tissue cells, including marrow fibroblasts, contain both types. In PMF, the role of collagen takes center stage. Collagen types I, 3, and 4 are significantly involved, each playing a distinct role. These collagen types are detectable through various staining techniques. Type 3 collagen increase can be identified through silver impregnation, while type I increase is revealed by trichrome staining. On the other hand, the presence of type 4 collagen is indicated by osteosclerosis. Interestingly, around 30% of patients with PMF show no fibrosis in their biopsy specimens, highlighting the variability of this feature. The increase in collagen is attributed to fibroblastic growth factors, including platelet-derived growth factor, transforming growth factor alpha, tumor necrosis factor A, interleukin-1A, and interleukin-1B. The consequences of marrow fibrosis extend beyond collagen alone. Marrow fibrosis leads to the expansion of marrow sinuses, increased vascular volume, and blood flow rate. However, it's important to note that bone marrow fibrosis isn't the sole diagnostic criterion. It can stem from various factors such as injury, immunologically mediated processes, or reactive responses. The fibrotic regions also experience neovascularization and endothelial cell proliferation, resulting in continuous stromal sheets of type 4 collagen and laminin. Notably, the deposition of type 7 collagen is also observed, potentially linking different collagen types in the context of fibrosis. Shifting our focus, let's explore extramedullary hematopoiesis, the process recognized through clinical signs of hepatomegaly or splenomegaly. This phenomenon is believed to stem from the release of clonal stem cells into circulation, which then gather in organs like the spleen, liver, adrenals, kidneys, and lymph nodes, contributing to conditions like hepatomegaly or splenomegaly. Despite its significance, the exact cause of extramedullary hematopoiesis remains unclear. Various factors, including chemicals, hormones, viruses, radiation, and immunologic elements, have been implicated, particularly in animal models. This process involves an increase in circulating hematopoietic cells. While fibroblasts are also present, they are a secondary anomaly and not clonal. B and T cells might also participate in this process. Extramedullary hematopoiesis leads to an elevated number of circulating hematopoietic progenitor cells, with CD34+ cells potentially being 300 times the normal count. The increase in circulating CD34+ cells serves as a distinctive feature of PMF. It aids in predicting the extent of splenic involvement and the risk of conversion to acute leukemia. In certain scenarios, effusions containing hematopoietic cells can arise from extramedullary hematopoiesis in areas like the cranial region, intraspinal epidural space, pleura, pericardium, and peritoneum. We delve into the pathogenic mechanisms, incidence, clinical presentation, and the intricate role of the immune response in this condition. Just like in PV and ET, the JAK2V617F mutation is a key player in the pathogenesis of PMF, present in about 65% of patients. But the genetic landscape doesn't end there. Additional mutations also make their mark, further shaping the disease. MPLW515L/K mutations are observed in around 10% of patients. And remember those mutations we discussed earlier? They're back: CBL, TET2, ASXL1, LNK, EZH2, and IDH1/2, all contribute to the intricate puzzle of PMF. PMF tends to affect individuals over 60 years old, and while some might not show symptoms, others experience a range of unsettling signs. Common presenting symptoms include fatigue, weakness, shortness of breath, palpitations, weight loss, and discomfort or pain in the left upper quadrant, often due to splenomegaly. When it comes to diagnosis, peripheral blood tells its own story. Abnormalities abound: dacryocytes, abnormal erythrocyte shapes, nucleated RBCs, and polychromatophilia paint a unique picture. Granulocyte numbers vary, ranging from increased to normal or decreased counts, sometimes accompanied by blasts and anomalous cells. Platelet count and morphology are equally diverse, with micromegakaryocytes making an appearance. To truly understand PMF, a bone marrow biopsy becomes essential. It's here that a plethora of findings emerge, revealing a tapestry of complexities. Bone marrow biopsy unveils intense fibrosis, hypercellularity of granulocytes and megakaryocytes, dysmegakaryopoiesis, dysgranulopoiesis, and expanded sinuses brimming with hematopoiesis. Neutrophils may exhibit functional impairments, while platelets might struggle with aggregation and reduced activity of platelet lipoxygenase. As we peel back layers, the immune response emerges as a significant player. About half of PMF patients experience altered humoral immune responses, featuring autoantibodies against various antigens. Circulating immune complexes, reactive lymphocytes in the marrow, and the development of amyloidosis all point to active immune processes at work. Collagen disorders often coincide with PMF, hinting that immunologic processes might stimulate marrow fibroblast activity, contributing to the intricate web of symptoms. Now we dive deeper into the interconnections among essential thrombocythemia, ET, polycythemia vera, PV, and primary myelofibrosis, PMF, guided by the enigma of the JAK2V617F mutation. The discovery of the JAK2V617F mutation brought both clarity and complexity to the world of MPNs. But it also ignited questions about why the same mutation can result in distinct phenotypes across ET, PV, and PMF. To address this fascinating discordance, four hypotheses have emerged, each offering a unique perspective. The discovery of the JAK2V617F mutation has illuminated MPNs but sparked questions about the relationship between ET, PV, and PMF. Disparity in JAK2 mutation occurrence, greater than 90 to 95% in PV, 50 to 60% in ET and PMF, how can the same mutation yield distinct phenotypes? Four hypotheses address this discordance. 1. Hematopoietic stem cell differentiation. The phenotype might be linked to the stage of differentiation of hematopoietic stem cells. 2. Genetic background influence. The genetic background of an individual might predispose them to a particular phenotype, with mutations in receptors like erythropoietin receptor, MPL, and granulocyte colony stimulating factor receptor potentially playing a role. 3. JAK2 tyrosine kinase activity. The level of JAK2 tyrosine kinase activity, often termed the dosage effect, could contribute. PV patients show higher activity than ET. 4. Pre-JAK2 mutation influence. A pre-existing mutation before the JAK2 mutation might establish a pre-malignant state, determining the ultimate phenotype. The JAK2 mutation then drives the malignancy. Differentiation program disparities and JAK2 mutations collaborate to create the phenotypic diversity seen in ET, PV, and PMF. The genetic background of individuals also plays a role. The involvement of receptors and factors shapes the predisposition to certain phenotypes. The level of JAK2 tyrosine kinase activity is a significant factor, with PV patients exhibiting higher activity than ET patients. The concept of a pre-JAK2 mutation setting the stage gains traction. This pre-existing mutation could act as a foundation, making the hematopoietic stem cells more prone to hyperproliferation and susceptibility to additional mutations like JAK2. Familial cases of MPNs provide compelling evidence for the pre-JAK2 mutation theory, lending strong support to this idea. A comprehensive model emerges, suggesting a continuum of diseases for ET, PV, and PMF. A pre-JAK2 mutation in hematopoietic stem cells could lead to hyperproliferation and set the stage for additional mutations like JAK2. The intricacies of receptors like MPL and erythropoietin receptor come into play. MPL's high expression in megakaryocyte precursors means a single JAK2 V617F mutation can drive megakaryocyte production, resulting in the ET phenotype. On the other hand, the erythropoietin receptor's sparse presence on erythroid precursors requires two JAK2 mutations for higher tyrosine kinase activity, resulting in the PV phenotype. MPL stimulation starts with the first JAK2 mutation and continues with the second, leading to continuous stimulation. Excessive thrombopoietin is linked to myelofibrosis, potentially progressing to PMF. Additional mutations in BCR/ABL1 negative MPNs influenced signaling pathways, tumor suppressor genes, and epigenetic regulators. JAK2 and MPL mutations remain main drivers, while negative signaling regulator mutations may enhance them. Epigenetic regulator mutations could be early or late events, influencing disease progression. Tumor suppressor gene mutations generally emerge during disease progression phases. In the grand scheme, it's likely that a combination of these hypotheses collaborates, guiding BCR/ABL1 negative MPNs through distinct phenotypes and the intricate phases of expansion and progression. Our exploration takes us to the realm of chronic neutrophilic leukemia, or CNL. Let's delve into this rare disorder characterized by the overproduction of neutrophilic cells in the bone marrow. Chronic neutrophilic leukemia, or CNL, is a unique clonal disorder that stands out due to its excessive neutrophilic cell production, leading to persistent neutrophilia in the peripheral blood and hepatosplenomegaly. It's crucial to differentiate CNL from other conditions, such as chronic myeloid leukemia, CML, which lacks the Philadelphia chromosome and BCR/ABL fusion gene. While the exact incidence of CNL remains elusive, it's undoubtedly rare. Only around 150 cases have been reported. However, the application of WHO criteria may have reclassified some cases as reactive conditions. The clinical presentation of CNL is characterized by hepatosplenomegaly, experienced by a significant portion of patients. About 25 to 30% of patients also face bleeding from mucocutaneous sites, gout due to the rapid turnover of white blood cells, and pruritus linked to the infiltration of neutrophils. In the peripheral blood, CNL is marked by a white blood cell count greater than 25 billion per liter, with a mild left shift. Neutrophils dominate the scene, and while bands, metamyelocytes, myelocytes, and promyelocytes make up a small fraction, up to 10%, of white blood cells, they are not dysplastic. However, toxic granules might be present. Bone marrow findings reveal a hypercellular environment dominated by neutrophilic proliferation. The myeloid to erythroid ratio is often greater than or equal to 20:1. Interestingly, red blood cells and platelets appear normal. Diagnosis of CNL requires specific criteria. Peripheral blood findings include a white blood cell count greater than 25 billion per liter, with over 90% mature neutrophils, and less than 10% immature neutrophilic cells. The blast count is typically less than 1%. Bone marrow analysis shows an increase in normal-appearing neutrophilic cells, with less than 5% myeloblasts. The megakaryocytes are normal or slightly left-shifted. Additionally, the diagnosis necessitates splenomegaly and the exclusion of reactive neutrophilia due to infection, inflammation, or tumors. Proof of clonality is essential, especially when ruling out reactive conditions. Genetic abnormalities in CNL are intriguing. Around 90% of CNL patients exhibit a normal karyotype, though abnormalities might emerge as the disease progresses. Some patients may develop karyotype abnormalities involving chromosomes 18, 19, 21, and deletions in various regions. Notably, CNL lacks the Philadelphia chromosome, the BCR/ABL mutation, and common gene rearrangement seen in other myeloproliferative neoplasms. JAK2 mutations are also rare in CNL. The prognosis of CNL varies widely. The disease is generally slow-growing and smoldering, leading to survival periods ranging from 6 months to over 20 years. However, the neutrophilia often progresses, potentially culminating in myelodysplasia and even transformation to acute myeloid leukemia in some unfortunate patients. Now turn our attention to chronic eosinophilic leukemia, a condition marked by clonal eosinophil proliferation and tissue infiltration. Chronic eosinophilic leukemia, or CL, is characterized by the excessive proliferation of eosinophils in both bone marrow and peripheral blood. These eosinophils can also infiltrate various tissues, leading to clinical complications. The clinical presentation of CL varies, but patients may experience a range of symptoms, including fever, fatigue, cough, angioedema, muscle pain, and pruritus. Cardiac complications are a concern, as fibrosis can develop in the heart, leading to issues like cardiomegaly, valve dysfunction, and thrombi formation. CL can also manifest with peripheral neuropathy, central nervous system problems, pulmonary symptoms, and even rheumatologic issues, highlighting the diverse ways the disease can affect the body. In CL, peripheral eosinophilia is a hallmark, with most eosinophils appearing normal. However, some abnormalities like eosinophilic myelocytes, hypergranulation, and vacuolization might be observed. Neutrophilia is often present, along with mild monocytosis, basophilia, and sometimes even blasts. The bone marrow is hypercellular due to eosinophilic proliferation, and characteristic Charcot-Leyden crystals may be visible. The presence of elevated myeloblasts, although below the 20% threshold for acute leukemia, is noteworthy. Dysplastic erythrocytes and megakaryocytes might also be observed. Bone marrow fibrosis in CL arises from the release of proteins from eosinophilic granules. This protein release can lead to the premature release of eosinophils and their deposition in various tissues. Diagnosis of CL requires eosinophilia greater than 1.5 billion cells per liter, accompanied by malignant features. This diagnosis is made by ruling out reactive eosinophilia and other concomitant eosinophilic malignancies. Differential diagnosis is crucial and involves excluding conditions like parasitic infections, allergies, Loeffler syndrome, cyclical eosinophilia, skin angiolymphoid hyperplasia, and collagen vascular disorders. Concomitant eosinophilia-inducing malignancies must also be ruled out. While no single genetic abnormality is specific to CL, the presence of certain karyotypic abnormalities can help rule out the condition. Common myeloid mutations like 18, 17q, JAK2, and specific genetic mutations, PDGFRA, PDGFRB, FGFR1, BCR/ABL, can aid in supporting the diagnosis. The prognosis for CL varies, with around 80% of patients surviving 5 years post-diagnosis. Unfavorable prognosis indicators include dysplasia, increased karyotype abnormalities, and elevated blasts. Mastocytosis is characterized by the neoplastic proliferation of mast cells, leading to their accumulation in one or more organ systems. This condition is classified into various subcategories based on type and severity, ranging from cutaneous mastocytosis to aggressive systemic mastocytosis. Mastocytosis can occur at any age, with cutaneous mastocytosis being more common in children and systemic mastocytosis predominantly observed in adults. Skin involvement is seen in approximately 80% of patients, leading to distinct clinical presentations and manifestations. The clinical presentation of mastocytosis can be quite diverse. Urticarial lesions activated by stroking, known as Willan flare, are a characteristic feature. Skin lesions often show melanin pigmentation. Symptoms are categorized into 4 severity groups: constitutional symptoms, skin manifestations, mediator-related systemic events, and musculoskeletal complaints. Hematologic findings may include anemia, leukocytosis, eosinophilia, neutropenia, and thrombocytopenia. In systemic mastocytosis with associated clonal hematologic non-mast cell lineage disease, the condition is often linked to myeloid malignancies. Diagnosis of mastocytosis typically begins with a skin lesion, which serves as an initial diagnostic clue. Different forms of cutaneous mastocytosis include urticaria pigmentosa, diffuse cutaneous mastocytosis, and mastocytosis of the skin. Systemic mastocytosis is diagnosed by the presence of mast cells in the bone marrow, often accompanied by fibrosis, hypercellular areas, and extracutaneous involvement. Genetics play a significant role in mastocytosis. A common mutation in the KIT gene, specifically in codon 816, is found in the majority of adult cases. Additional mutations, such as RUNX1/RUNX1T in AML and JAK1 in MPN, contribute to hematopoietic clone proliferation. The prognosis for mastocytosis varies widely based on the form and severity of the disease. Cutaneous mastocytosis in children often has a favorable outcome and may even regress at puberty. Milder forms of mastocytosis generally follow a benign course and are associated with a normal lifespan. However, aggressive forms, such as aggressive systemic mastocytosis, mast cell leukemia, and mast cell sarcoma, require chemotherapy and have a poorer prognosis. Stay up to date with our latest videos by hitting that subscribe button and activating notifications. Be the first to know when we release new and exciting content. Don't keep all this valuable information to yourself, share this video with your friends who might find it interesting and beneficial. If you have any questions or comments, feel free to leave them down below. Until next time, take care and goodbye.